Hi everyone. Thank you for joining us for the Biodesign competition hosted by the Biodesign and Innovation Committee. My name is Deepak Iyer and I'm a second year at GW School of Medicine and also the new chair of the Biodesign and Innovation Committee. I'm here with Selena Shea, who is a third year at Brown and also the new chair of the Biodesign competition. As a brief introduction, our committee hosts an annual Biodesign competition where students are challenged to solve problems faced in IR in a collaborative setting with peers and IR mentors.
The competition kicked off in September with the release of this year's prompt. Over the course of 3 months, each team shadowed IR physicians and worked closely with a mentor to identify a problem, brainstorm ideas, and design a model of their proposed solutions. We received 11 unique solutions, and after an initial round of judging, 2 finalists, Team PocketDoc and Team Chatter, were selected to give their pitches today on their innovative ideas. Each presentation will be followed by a Q&A session where the teams will field questions from the 5 esteemed judges who have joined us today. Before we start, I want to take a brief moment to thank the panelists who are here today, as well as the wonderful preliminary judges who reviewed the team's proposals. We also want to acknowledge everyone else who've helped us make this possible, and a quick shout out to all the teams that participated this year. And finally, a big thank you to SIR for this opportunity to showcase the Biodesign competition. Without further ado, I'm going to turn this over to the first team, Team PocketDoc.
Good afternoon. My name is Lindsay Arndt, and on behalf of my whole team, I'm here to present PocketDoc, a solution to empower patients to better advocate for themselves. Before we discuss the impacts of COVID-19 and the problem we solved, I'd like to introduce you to Rodney. He's a 65-year-old grandfather of 2 with a history of peripheral arterial disease. Rodney has been struggling with managing his symptoms and keeping track of his medications. He has difficulty remembering which pills to take, if he's reached his walking goal for the week, and when his next appointments are. Some of Rodney's doctors call him non-compliant. Rodney's providers are concerned that his history of non-compliance makes him less eligible for a procedure to treat his PAD. Rodney's difficulties navigating the system isn't unusual or unexpected. For patients to navigate our healthcare system, they need to be highly motivated to seek care. In our office visits, a majority of our patients cannot recall more than 50% of what we share with them. For historically underserved and minority patients, these difficulties are exacerbated by structures that are not built to serve their needs. When all our patients undergo procedures, they have 3 questions in mind. What's going to happen to me? Am I going to be okay? And what will recovery look like? Patients need a solution that provides better education and care coordination in our fragmented health system. Rodney installed PocketDoc prior to his angioplasty for suggestions on how to improve his health. His notification bar makes sure he's staying on top of his medications, walking program, and appointments with doctors. He uses his symptom tracker and recommendations page to have better discussions with his care team. Through medication and symptom tracking on PocketDoc, Rodney regularly takes all his prescription medication and tracks his symptoms through periodic surveys. Now, Rodney's doing everything he can to fight his PAD. The PocketDoc isn't just for Rodney, it's for Cynthia too. Cynthia is a 53-year-old African-American mother of 1 suffering from fibroids. Since the pandemic started, connecting with her doctor has been challenging, and she's concerned about how she'll feel after her procedure. Cynthia downloaded PocketDoc to record her symptoms after her fibroid embolization and uses it to track symptoms like constipation, fatigue, pain, and bleeding. With PocketDoc, Cynthia understands how she's progressing post-surgery and gets alerts to red flag symptoms. She finally feels confident and excited to reach out to her doctor with data-driven questions and concerns. PocketDoc facilitates dialogue and collaboration between patients and their healthcare teams. This dynamic has the potential to reduce unnecessary in-person follow-up and minimize COVID exposure risk. PocketDoc's accessibility and potential for telehealth integration addresses health inequities by providing a communication channel to the historically underserved populations. PocketDoc directly benefits Rodney and Cynthia by giving them the ability to coordinate their care with providers, stay on top of their health goals with a user-friendly interface, and encourage adherence through its emphasis on education. For physicians, the health data imported by PocketDoc provides a more accurate look at patient recovery, reducing the amount of potential bias in decisions regarding patient care. PocketDoc will leverage technology to enhance healthcare by providing patients with a user-friendly platform to centralize and coordinate their care, filling the need for high-quality, personalized healthcare engagement. For patients, as you can see on the top left, PocketDoc will enhance shared clinical decision-making, increasing the potential for early intervention with evidence-based analytics, and provide patients with more personalized recommendations. For institutions, improved patient outcomes, decreased readmission rates, and valuable quantitative feedback on institutional performance are only some of the potential benefits. For researchers, the patient data collected will provide fodder for scientific research, which will provide a new communication channel for patients to record symptoms that would otherwise be unnoticed. For physicians, seen on the top right, health data integration will increase provider satisfaction through decreasing administrative time and increasing access to IR procedures. This is what it would look like for Cynthia if she was your patient. Again, she's been suffering from fibroids and heard there's a procedure that could prevent her from undergoing a hysterectomy. After a clinic visit with her physician, Cynthia learned UAE could help her. At that visit, Cynthia's doctor recommended PocketDoc to track her symptoms and help her learn more about fibroids and her upcoming procedure. Cynthia felt empowered to ask her physician questions about what to expect after her procedure and how much time to take off work. Cynthia even messaged her doctor through the app with a follow-up question from their visit and was able to receive a response without the hassles of logging into her patient portal or calling the IR clinic. When the time came for her UFE, Cynthia felt empowered and equipped thanks to her time with her physician and resources PocketDoc provided for her. After her procedure, Cynthia continued to use PocketDoc, recording the symptoms, severity, and burden, and was able to fill out her 3- and 6-month clinical questionnaires on her phone. By showing her doctor trends in her symptoms, they were able to work together to track her recovery by correlating her symptom burden and timeline. In addition to peace of mind, Cynthia feels fulfilled that she's participating in research to help other women like her recover from fibroids more quickly. PocketDoc is incredibly useful to mitigate exposure risk in the COVID era with this medication, symptom, and red flag tracking. By providing a reliable method to track the patient's recovery journey, physicians and patients can cooperate more successfully to determine the best next steps. Today, we need a variety of ways to keep non-emergent issues from overwhelming healthcare infrastructure. PocketDoc is the perfect tool to enhance remote symptom tracking and follow-up while empowering patients in the clinical decision-making process. As a new app, PocketDoc faces many challenges, including lack of brand awareness and financial support. But features such as free in-app store accessibility and a user-friendly interface encourage daily patient interaction. PocketDoc also faces market threats, including regulatory hurdles and collection of clinically relevant data. However, the app has a wealth of potential for growing through AI and data integration and can benefit hospitals and researchers, as well as patients and physicians. The team that made this solution possible was a collaboration between Morehouse and Emory Medical Schools, as well as Georgia Tech. We're grateful for the opportunity to collaborate across schools, which enabled us to think creatively, innovate, and design a solution to improve patient care. Through evidence-based guidelines, PocketDoc educates and empowers patients before and after their procedure, alerting users if the recovery is not progressing as expected. By improving care collaboration, PocketDoc bolsters trust between patients and providers, leading to enhanced clinical decision-making, strengthened communication, and improved clinical outcomes. PocketDoc brings patient-centered care into the 21st century. Thank you for your attention. We'd also like to thank our advisor, Dr. Burkew, and all the Biodesign committee members who made this competition possible. When you see this recording, I'll be with my family and friends on my bachelorette party, and another member of the team, Chris Awad, will be happy to take your questions. Thanks.
All right, thank you so much, Team PocketDoc, for your great presentation. We will now turn it over to the judges for any questions they may have.
So one of the issues that happens when dealing with patients is they often misinterpret. When you write down what possibly they might be feeling or going through, they misinterpret. How do you feel you might deal with that issue?
So just to make sure I understand your question, is the question about interpreting what the patient is telling the provider or what the provider is telling the patient?
No, what the patient, so the patient will have instructions from you, and you say you might be, you might be feeling this back pain, for instance, and patients have difficulty stratifying because perceptions of their individual symptoms are so unique to that patient. And so have you considered how you might sort of make things specific or deal with that issue of different patients' perceptions of what might be?
Yeah, thank you for the great question. I think, what we've done in addition to thinking about that is thinking about who's going to be the person providing that data in addition to the way that the patient is attempting to answer the question. Because for a lot of us, our patients are actually collaborating with their sons, their daughters, their grandchildren to actually interface with the healthcare system. So by understanding that upfront and hopefully, developing surveys that do more than just ask patients about quantitative pain metrics on a 1 to 10 scale, but being creative about the way that we can capture that data through heat mapping, through being able to engage with properties on their phone to locate specifically where the pain might be or how the pain aura moves from day to day. Those creative solutions, in addition to knowing who's providing that information, is what we're hoping will give us a lot more power to the questions we're asking and the data we're collecting from patients.
So you're going to make it objective as well as subjective then?
Yes.
Hi, I have a question. Miles Conrad here from UCSF. How do you deal with the legal risk of having a bot help make medical decisions?
Yeah, and I love how I'm sure the panel, with all their experience, is forward thinking to kind of the problems that we're inevitably going to interact with through bureaucracy and through the challenges of rolling something like this out. I think the way I'd like to answer that question is by thinking through what is important and what can we automatize. And so there's a percentage of correspondence that comes to and through the hospital systems that can be triaged efficiently and with the patient. And I think that's how we're attempting to quantify some of the features that we're hoping to roll out in a pilot study, for instance, where we can think through what are the 5 or 10 or 15% of calls and questions that we can answer efficiently and effectively without incurring that risk, to then be able to triage other questions appropriately as well.
And a quick follow-up would be, what is the legal precedence for health chatbots and other bots in medicine? Has there been much written about it?
So I can personally share that I know from my research that there hasn't been a lot written about it. I wouldn't be able to answer confidently what the legal precedent is around how chatbots or automated programs are allowed to engage with patients for the purpose of triaging or stratifying what patients might need. I just know from our experience as a team that when we've looked into the literature, there have been questions about AI chat functionality that have been attempted to be answered, but there hasn't been comprehensive work, to my knowledge, about that functionality, especially in IR.
So, Chris, have you thought about how you're going to, sort of gather the data that shows that you're effective?
Yeah, thank you for that question, because we've brainstormed so much about this, and I think there are 2 real avenues for quantifying engagement. The first avenue is respondency rate, understanding for ourselves how we can get that user engagement to an effective enough level where the data that we collect can be trusted. Again, I've referred to this as kind of increased power for that data. The second is to actually quantify the engagement on the app. We can tell how much time patients are spending per page, per survey. Understanding those things can help us not only prioritize where we marshal resources in the future to be able to intervene, engage patients, et cetera, but also where we could probably spend time improving things. So we're hoping to actually use a lot of that quantitative data from the question you've asked to work on how we can get better and to understand what patients might need more from us.
Right. So I guess, sorry, I didn't ask that question very well. Really what I was thinking is at the end of the day, someone's going to have to pay for this if this is going to actually perpetuate itself. And so when you're thinking of, first of all, who do you think will pay for it? And then second, how are you going to basically gather the data and quantify it to give them good reasoning why they should pay for it? Other than the good vibes of, that the patient has, patients in control of their care. All those things are great. It's getting someone to pay for that. That's important.
Yeah. And I think that's exactly the answer that a lot of the physicians we've spoken to ask us. And so the way that we think through that is by, one, developing a methodology that's steeped in clinical evidence, understanding what does it mean for patients to engage with a platform? What does it mean to collect data in a survey on a phone? Those are still clinical questions that, as I've reflected in the last question from our research, haven't been properly answered. And so once we can develop a methodology that is consistent with the rigor that we all want to be able to bring for our patients, we're hoping then to be able to incentivize patient engagement by giving access to data in secure ways to the various stakeholders that engage with their care, whether that's the physician, the institution as a whole, so that they can understand both quantitative and qualitative feedback metrics, if those are the things they want to collect, in addition to other participating stakeholders who might be interested in the way that anonymized data coming from the patient can be used for their research purposes or otherwise. Thank you again for the question.
You're welcome. I'm sorry, we're a little bit at a disadvantage here. I can't see, I'm not familiar, I can't see how many other panelists here are, if they're ready to ask questions. So Selena, maybe push on some of these other guys to ask questions.
All right, sure. Dr. Shukla, do you have any questions for Chris?
I have a question. I can ask a question. What do you think your dream use of this application is for? When you were brainstorming about this, what would be the ultimate use of this tool?
Yeah, I love this question because I think it is something that I'm selfishly incentivized to answer. I was drawn personally to IR because the community is forward thinking. They're driven with adaptations in technology that they want to take on to better their patients. And out of that, and out of the inspiration of that community, I think all of us were empowered to think through an ideal solution. That being one where patients don't need to be afraid and are incentivized to engage with healthcare in ways that are simple, quick, and straightforward, so that we can get, as providers, the information that could be clinically efficacious for us, could actually change clinical management. And so when we brainstorm that idea, it would be a tool that allows for care coordination within an institution and with patients' physicians, giving them priority and access to education as the means for being compliant with their medications, being adherent to their appointments, and making decisions for their health that they're empowered to do through our platform and through the reduced burden to accessing care that we're hoping to provide as a tool for everyone.
All right, so thank you, Chris. Unfortunately, we will have to transition to the next team. So yeah, we will go ahead and learn more about Chat IR.
Thank you all.
Good afternoon, everyone. My name is Adar Shamala, and I will be presenting on behalf of my team at the University of Maryland School of Medicine on our efforts towards the development of Chat-IR, or as we like to call it, Chatter. Chatter is the first patient-centered interventional radiology chatbot designed to improve access to healthcare and reduce unnecessary emergency department utilization by empowering patients with 24/7 access to interactive and evidence-based support. Now, I think we can all appreciate that COVID-19 overwhelmed our healthcare system. This was only exacerbated by unnecessary emergency department visits, a common and costly theme of our healthcare system. Downstream of these, COVID-19 circumstances have challenged hospitals and clinicians to somehow sustain follow-up and elective care without the infrastructure to do so safely in person or effectively remotely. For patients, rather than being able to consult with their physician, have often resorted to preemptively utilizing the ED and in many cases, even delaying emergency care. Now, on the solution side, the natural response in this space has been to focus on telehealth or somehow augmenting the efforts of physicians, whether via home visits or somehow making physicians more available or efficient. However, given the unprecedented pressures that COVID has placed on our healthcare providers, we thought it was time for a solution that is novel in that it is more or less hands-off for the clinician and instead augments the efforts of the patient via education and supporting them to feel more empowered with their care. So we wanted to find a way to remotely educate, support, and empower patients in the pre- and post-operative setting to improve patient outcomes and reduce unnecessary ED utilization in the COVID-19 era and beyond. Now, with the solution focused on education and empowerment, we did not want to overlook existing challenges in this space, which include standardization and ensuring the support was accessible regardless of socioeconomic status. Finally, tying this all together and making it even more relevant for IR, we also found a study that followed almost 1 million invasive outpatient procedures and found the highest ED revisit rate was for procedures done by IR. And so we have developed Chatter. Chatter is a SMS text and messenger-based chatbot developed to provide real-time assistance in the pre- and post-procedural settings using provider-crafted direction, images, and video tutorials. Our platform primarily aims to support patients in managing expectations after a procedure, being more self-reliant in addressing simple post-operative complications, and elevating a concern directly to the IR care team when necessary. So as you can see on the demo on the right, the patient is text in blue and the bot is in white. The patient is able to communicate to the bot that they recently had a gastrostomy tube placed, and then the bot will provide some aspects of the post-procedural experience that it may be able to assist the patient with, whether that's new symptoms or G-tube problems or FAQs. The patient will then communicate to the bot that they're having some problems with their G-tube. The bot will ask the patient to specify a little bit regarding their G-tube issues. The patient will then, with the click of a single button, communicate that their G-tube is leaking. And as with all responses with Chatter, Chatter will first focus on managing the patient's expectations. So communicating with the patient whether this is a common complication after their procedure or whether this is something they should be a little bit more worried about. Then Chatter will focus on educating the patient on common causes of these complications, as well as some proven solutions that the patient may be able to apply in their home or with the assistance of their physician over the phone. So in this case, the bot will tell the patient to make sure that their tube is secure against their skin. And of course, if necessary, the bot can elevate the concern to a healthcare provider. And so for our first design of Chatter, we wanted to focus our iterative development around a single high-frequency IR procedure with a high rate of readmission. So we focused on gastrostomy tubes. There's actually a strong body of literature pointing to a significant and unnecessary resource utilization for care and maintenance after G-tube placement. We found that of the almost 300,000 G-tubes placed in the United States each year, about 20 to 30% of these patients return to the ED within 30 days of placement. Even more remarkable is that 40% of these visits to the ED were found to be unnecessary and were considered issues that could have been resolved with better patient education over a phone call or in the outpatient setting. Based on research estimates, about 45% of these unnecessary visits were for granulation tissue, another 25% for minor clogs, and about 15% for leakage. Now, these visits on average costed $1,200 and required spending 5.5 hours in the emergency department. Extrapolating this data to our healthcare system, this suggests a $43.2 million in unnecessary healthcare expenditure relating to G2 maintenance. Now, we really strongly believe that an accessible, on-demand educational tool like Chatter will be extremely effective in supporting patients and caretakers to handle minor post-op problems on their own, or recognize that their complication can be addressed over the phone or in the outpatient setting rather than in the ED. All of this without requiring any significant resources or time from the clinician. So a couple of other snippets from the literature. One paper reported that even in the outpatient setting, about 1/3 of those visits could have been easily addressed over the phone or by a caregiver. And other papers suggested that a significant percentage of patients coming in for dislodgements or granulation tissue were problems that could have been taken care of at home, given a more dedicated educational program or improved caregiver education on gastrostomy tube handling. To further illustrate the potential and role of Chatter in this space, the data on ED visits within a year are even more compelling. So the previous data was on ED visits within 30 days of placement. When we look at ED usage within a year, we see that 83% of ED visits were not related to emergent concerns, with one study even finding that 33 patients visited the ED a whopping 138 times over a 2-year period for complications relating to their G2. Now, to put this a little bit more into a real world context, we have a patient scenario here. So we have Clara, who's an 8-year-old female who recently suffered a stroke secondary to her sickle cell anemia. She recently underwent a G2 placement as her stroke resulted in an inability to feed PO. Her primary caretaker and mother, Denise, is a busy mother of 4, working 2 jobs with a household income of only $28,000. One evening, before Denise heads to the night shift of her second job, Clara's G-tube appears to be clogged. Denise tries to contact her IR clinic, but cannot reach anyone as it is after hours. With low-income living conditions, Denise cannot afford internet service and does not have a smartphone. She panics as she cannot feed Clara her formula. Denise calls in and misses her work shift and instead takes Clara to the ER. They spend 4 hours there before they are seen, and the issue is resolved in 5 minutes by the on-call IR. In this world, Denise had to miss her work shift, losing a paycheck and rapport with her manager. Turns out she also caught a novel respiratory virus while she was waiting in the ER for 4 hours. To make things even worse, 2 weeks later, she received an ER bill for $980. Now enter the world of Chatter. After Clara's recent G2 placement, her IR physician informed Denise of a new patient-centered educational tool called Chatter. When Clara's G2 became sluggish before Denise's work shift, Denise simply spent a few minutes with Chatter, learning about common causes of clogs and potential solutions. She was able to resolve the clog and made it to her work shift 5 minutes early. So what you're seeing here is the SMS version of Chatter. In our initial example, that was the messenger version of Chatter, which could be used across a number of platforms, including Facebook. So in Chatter, in a world with Chatter, Denise's access to healthcare support for her daughter is significantly improved. Denise is able to save time, money, and most importantly, maximize the care for her daughter, Clara, despite their low income circumstances. Chatter will also feature a follow-up text within a couple of hours of anyone inquiring the platform of an issue to ensure that they were able to resolve their issue, and if not, to connect the patient with a provider. Now, this is not a surprise to anyone here. Chatter certainly cannot do it all. And as you can see in this demo, in the case of a rash, Chatter will communicate to the patient that a rash is something that needs to be evaluated by a qualified healthcare professional. The patient is then connected to a member of the clinical care team who will be using Chatter's interface via an app or a computer. The patient can send the clinician pictures of their rash, and the clinician can ask additional questions, eventually becoming comfortable enough to prescribe the patient an antibiotic cream. A process that in the past would have likely taken days or weeks, resulting in the rash getting worse and requiring time and resources for the patient and clinician. An additional feature of Chatter will be a healthy practices opt-in option. So as we all know, preventing complications are much less effort than resolving them. So in addition to focusing on education and communication, Chatter will also focus on healthy practices by incorporating an opt-in option for patients to receive text reminders of healthy practices to minimize the occurrence and progression of complications. So there's a quick example of something a patient might get, every couple of days or once a week. And so another common question is, why such a focus on an SMS text platform? And I don't think this is a surprise to any of us, but access to a smartphone and internet is intimately tied to household income, age, and education status. So while Chatter will definitely support an app platform in the future, we felt it was important to ensure robust utility at the level of an SMS platform to ensure Chatter support was accessible by vulnerable populations. In terms of technological impact, at the healthcare system level, we believe Chatter will reduce unnecessary ED visits and the associated hospital costs, as well as minimize COVID-19 transmission for all parties by curtailing avoidable readmissions. At the clinician level, Chatter will help in uniformly supporting patients of all socioeconomic backgrounds with the same standardized information, as well as reducing the number of unnecessary in-person or virtual consults, all in a very effortless and hands-off fashion for the clinician. At the patient level, Chatter will reduce the health risks and costs associated with ED visits, and also augment patient autonomy and hopefully make them feel more connected to their care as well as their clinicians. In terms of competitive landscape, we really don't believe there's any technology out there like Chatter. The most important differentiating features for Chatter compared to complex symptom checker chatbots, such as Babylon Employee Health, is that Chatter has a defined role in pre and post-procedural care and shows a clear utility for both the patient and the physician. Additionally, site-specific clinicians will be involved in the design and implementation of Chatter, so continuity of care will be facilitated, and clinicians will know exactly what information is being delivered to patients in particular context. Additionally, Chatter will not require PHI, it will not require an app download, and of course there will be opt-in options as well as no cost to the patient. So as with any new technology, we understand that there are some well-placed concerns surrounding Chatter's role in potentially facilitating excessive risk by providing patients with information that may be acted on or interpreted in a way that is different than was intended. We hope to combat this risk by first strictly marketing Chatter as a pre and post-op educational tool. Similar to current discharge forms and online WebMD pages, we have carefully crafted the language used in Chatter to be focused more on education and information rather than directions or directives. Additionally, we will continue to iteratively test and get feedback from patients and clinicians to help us identify language in the workflow that may facilitate unnecessary risk if misinterpreted, or points that may require expertise beyond that of the patient. In terms of our business model, by reducing unnecessary ED utilization, encouraging healthy post-operative practices, and minimizing the risk associated with ED visits, Chatter will reduce health care expenditures. As a result, we foresee insurance companies and hospital systems being an important component of the market for Chatter. Similar to how Livongo, Level 2, and other telehealth support companies have struck multi-million-dollar contracts with Kaiser and United Health Group for access to their services, we believe there's a strong incentive for hospital systems and insurance companies to provide their patients with access to Chatter. Finally, in terms of our timeline, we will continue iterative development, and we are currently working with our tech transfer team at the University of Maryland for IP protection. We hope to start the application for IRB approval in mid-April and begin clinical trials in the mid-summer and hopefully have Chatter testing in the hands of patients by then. So this is the incredible team of students from the University of Maryland School of Medicine and our incredible advisors from UCLA IR. Thank you for your time, and I'm happy to take questions.
All right. Thank you so much, Team Chatter, for talking about your product. And now we'll open it up for the judges to ask some questions.
Hi, great job, great presentation. I have two questions. One is, you showed a great example of a gastrostomy tube and post-procedure issues in care. we do a lot of simple and complex cases on patients that are very complex themselves. So how do you see the platform working for when things get more complex and the feedback it can give, or is it only for like more straightforward procedures and patients?
Sure. Yeah, I think at this stage, just because of the potential risk associated with handling more complex issues and more complex cases, chatter will mostly be focused on relatively simple, kind of straightforward post-procedural issues or pre-procedural questions that patients may think needs to be seen more urgently, but can actually be seen in an outpatient setting or be handled over the phone. So right now, I think we're focused on kind of those high volume situations that are actually causing a lot of waste in our healthcare system.
And my other question was the recommendations. What kind of data or evidence, like where are you getting the recommendations from, and how is that being sourced?
Yeah, so I guess for the particular example of G-tubes, I think it's mostly our data is going to be coming from kind of the current literature or the kind of current accepted standards for maybe flushing a G-tube or trying to fix a leak. So it'll kind of come from, I think, a consensus of the body of literature, as well as there will be some kind of site-specific customization that we mentioned in the presentation. So clinicians may have particular preferences for their patients in handling certain issues. And so because of the kind of onboarding with a site-specific form, clinicians will have the option of either kind of choosing from our pre-filled recommendations that will be given to patients, or actually filling in their own preferences for how patients should handle certain issues.
Thanks.
All right, and then we have a question sent in by Dr. Shukla. How do you plan to get patients and doctors to participate? The biggest challenge in the space is gaining users. So what marketing strategies do you have? And number two, how do you plan on making money and making this sustainable?
Right, so I think for the first question, we'll probably have to run kind of our own small clinical trial or IRB to kind of show that chatter is something that patients are willing to engage with, especially considering that it is available on an SMS platform. And then based on that data, kind of showing that there is patient engagement and that they're, based on surveys that patients did use chatter, and maybe it prevented them from making an extra phone call or making a trip to, an appointment to the outpatient clinic or even going to the ED. So collecting that data and kind of, proving from a data perspective that chatter is effective in all of those aspects will, I think, kind of be one of our major marketing points. So, towards the end of the presentation, we're looking to hopefully maybe have chatter in the hands of patients, at least the first iteration this summer. So I think that will be for the goal of that. And then in terms of making money, I think, as you kind of saw from some of the introductions, there's actually a large amount of money that will be saved from just, preventing one or, a handful of patients from going to the ED for an issue that maybe could have been solved over the phone or in the outpatient clinic. So I think, having a price point for chatter and then just showing, if you save like 4 or 5 patients over a year, that chatter will easily pay for itself. And definitely save the patient money as well as the clinician, and have less, I guess, time on either side being used as well.
And so some follow-up questions from Dr. Shukla. So who pays for the service? Money saved doesn't necessarily equal money for the app. So do hospital systems pay?
Yeah, I guess, the future goal would be like hospital systems that want to provide their patients access to chatter, or insurance companies, or even clinicians having their own clinic would pay kind of like a monthly fee for, or an annual fee for support, tech support and continual customization, as well as the data collection that will be involved for the implementation of chatter.
Okay, thank you. And now, if any of the other judges would like to ask their questions.
Yeah. Hi, Darsha. Lindsay McCann here in University of British Columbia. That was a really wonderful presentation. Congratulations on all your work.
Thank you.
I think a couple of things come to mind when I see this. The first is, do you think you're going to have any regulatory issues?
Yeah, so that's a good question. I think actually, especially I guess particularly testing it initially, it seems that a lot of universities, at least specifically where our mentors work at UCLA, actually have a pathway, I guess, for things that are focused on quality initiative or quality improvements that actually don't involve kind of large regulations for getting it into the hands of patients. So I guess from the current standpoint, that maybe we don't foresee having too many large regulatory issues, especially kind of, based around everyone's worries about, patients maybe taking advice and using it in the wrong ways. I think we're really going to focus on minimizing the risk and focusing it as an educational tool that patients will, like I said in the presentation, kind of be given more educational and proven solutions rather than directions and directives.
Yeah, I mean, I think, certainly just free advice is worth what you pay for it, but I would strongly investigate that. There's a lot of, as you know, there's a lot of predicates for what you're doing out there already. Second question is, one just coming back to what Susan said was that, like last time we tabulated about 153 unique procedures that interventional radiologists do, which is different than any other specialty. We're an inch deep and a mile wide. And so how do you think you might stratify those opportunities, of those? I think you chose a great one in gastrostomy, but how are you going to stratify all those opportunities?
Right. Well, I think similar to kind of our G-tube approach, I think we'll focus on maybe the high volume procedures, that there's a good amount of data in terms of kind of the post complications that patients may experience, such as pain, or if there's a lot of information kind of pointing to the idea that patients have a lot more uncomfortable or are more comfortable or have a lot more pre-op questions. So I think we'll focus designing chatter kind of in terms of adding on procedures around those. And then hopefully based on those data or more data that comes out in terms of pre or post-op issues that patients run into, we'll slowly also add those into chatter. Again, just kind of focusing on being able to handle most of the pre-op questions in terms of like, what will it be like living with a G-tube, or what are the logistics of my procedure in terms of what I should bring, and then simple post-procedural complications that they may encounter that should, be able to be handled by the patient or over the phone or by a caregiver.
Great answers. I'll pass over to one of the other judges. Hold on.
Hey, it's Miles Conrad from UCSF. Adarsha, that was a wonderful presentation. I really enjoyed that.
Thank you.
If who's going to be at the other end, do you think, managing all this data stream that's coming back to the provider team? You mentioned there was a clinical care team member that's managing that. Do you think, like, let's say I'm on call this weekend and I'm all of a sudden getting these alerts on my phone, just like my MyChart, which is huge, and I can barely respond to my charts. How do I manage the data stream from this application?
Right. That's a great question. So just from the physician perspective, they will have kind of like an app or a computer interface. You won't have kind of text coming directly to your personal number. But I think we foresee some issues depending on availability. So there will obviously be a wait time for patients needing to be responded to. So, patients will be indicated that maybe there's a 10-minute wait time for someone to review the picture of your rash, et cetera. But I think I guess a lot of clinics may have kind of a dedicated educational nurse for G-tubes or similar procedures, or it could even be handled by someone with, some familiarity with the procedure, such as, like the head charge nurse. Or someone to, maybe it could even be split responsibility between multiple clinicians in terms of having access to this kind of messenger database of chatter and then being able to respond as issues come up and people are available.
Do you think this would reduce physician or make physicians more efficient?
I think by kind of taking off the kind of burden of a lot of issues that maybe patients, kind of like the literature said, that patients can handle at home, or patients like issues like granulation tissue that kind of look more severe, but that patients don't actually really need to maybe come into a clinic for, or the ER for. So I think by freeing up that time, there will be a little bit of an upfront kind of time investment, because it will be site specific. So the specific clinician on site will kind of have to become familiar with chatter and kind of understand what information patients will be getting in different contexts. But I think after that, the bot really will save quite a bit of time for the clinician, just in terms of phone calls and outpatient clinic visits.
One quick question to Joji from LA. Adarsha, a great presentation. What about just for, my main worry is safety, like, G-tubes, though they're a small procedure that can have significant complications, including life-threatening peritonitis and major bleeding, even potentially delayed. Though rare, it can happen. So how do you, what's your sensitivity for something of that event? Because it has to be pretty high.
Right. So I guess that's something we'll get more data out when we test it. But I think from the get-go, we'll kind of, be very aware of those issues and kind of design chatter's responses to, try to mitigate those things from happening. So in terms of maybe like before handling a G-tube clog, and before the patient might be suggested to flush it with something, we'll first indicate to the patient that they should make sure their G tube is in proper position. So based on applying some pressure to the tube and making sure it's lined up on the line before they actually do anything. So hopefully preventing those complications and kind of, I guess, just organizing the language around and eliminating any of those possibilities from potentially being incurred by the patient, and then providing them with potential solutions.
All right, great. Thank you so much, Adarsha, for answering all these questions. I just want to give a big thank you to the two teams for your amazing presentations, and the judges for all your questions and thoughtful feedback. We'll now be giving the judges some time to deliberate, and then we'll be announcing the winner later today. Thank you.